Greetings. I will be your oral board's examiner today. Before we begin, you must be in a quiet space, where there is no one else speaking and no media of any sort playing, just as it will be in a real oral board examination. Please confirm that you are in a suitable environment for this simulation to take place.
Absolutely. I can confirm that I'm in a quiet and suitable environment with no distractions. Everything's set up just like a real oral board situation, so we're good to go.
Understood. Let's begin. A 50-year-old man with a history of NSAID use presents with sudden, severe epigastric pain radiating to the back. He appears acutely ill and his abdomen is rigid. How would you proceed?
All right, that definitely raises concern. With that history of NSAID use and the sudden, severe epigastric pain radiating to the back, plus a rigid abdomen, I'm definitely thinking about a perforated peptic ulcer. That's a surgical emergency. My next step would be to get imaging, like an upright abdominal x-ray or a CT scan to look for free air, and of course, we'd start resuscitation and surgical consult right away.
Please be specific about your immediate actions. Which imaging modality will you order first? And what are your initial resuscitation steps in detail?
Absolutely. So the first imaging modality I'd order is an upright chest and abdominal x-ray to quickly check for free air under the diaphragm. If available and time allows, a CT scan of the abdomen would give even more detail. As for resuscitation steps, I'd immediately start the patient on IV fluids to stabilize them, administer IV pain control, and begin broad spectrum antibiotics, given the risk of perforation and infection. I'd also contact surgery right away for an urgent consult. Let me know if you'd like me to go into any more detail.
Upright chest and abdominal x-ray ordered. The x-ray shows free air under the diaphragm. You've started IV fluids and broad-spectrum antibiotics. What specific antibiotic regimen, dose, and route are you using at this point?
Sure, let's be specific. I typically start with something like IV piperacillin tazobactam. For example, a dose of 3.375 grams every 6 hours. If there's a concern about broader coverage, you might add metronidazole to cover anaerobes, or you could go with something like IV ceftriaxone plus metronidazole as an alternative regimen. All of these would be administered intravenously. And of course, with free air confirmed, surgery is definitely on board at this point for emergent management.
Understood. The patient has received IV piperacillin tazobactam 3.375 grams. Now, given the confirmation of free air under the diaphragm and the clinical picture, what is your next step in managing this patient surgically?
All right, so with the confirmation of free air and a clinical picture consistent with a perforated ulcer, the next step is to proceed to the operating room as soon as possible. The surgical team would perform an exploratory laparotomy to identify and repair the site of the perforation, typically a Graham patch or a similar repair for a perforated ulcer. In addition, the patient would be managed with continued IV antibiotics, supportive care, and post-op monitoring. So the key here is urgent surgical intervention now that we have that confirmation.
You proceed with an exploratory laparotomy. On entering the abdomen, you find a 1 centimeter perforation on the anterior duodenal bulb, with contamination of the peritoneal cavity. What operative steps will you perform next? All
right, so with a 1 centimeter perforation in the anterior duodenal bulb, the next operative steps would be to first thoroughly irrigate the peritoneal cavity to clear out any contamination. After irrigation, you'd proceed with repairing the perforation itself, and a common method is to perform an omental patch repair, also known as a Graham patch, where you take a piece of the omentum and suture it over the perforation to seal it. You'd ensure hemostasis, place drains if needed, and then close up. Post-operatively, you'd continue with supportive care, IV antibiotics, and monitoring. So that would be the standard operative approach from here.
Omental patch repair is performed. You complete the omental patch, secure it with sutures, and irrigate the peritoneal cavity. The patient stabilizes intraoperatively. The abdomen is closed. The patient is now extubated postoperatively. What additional postoperative management will you provide?
Sure. So after a successful omental patch repair and the patient is stable and extubated, the key postoperative management steps would include continuing the IV antibiotics to prevent infection and treating any contamination that was there. You'd also manage the patient's pain with appropriate analgesia and start them on proton pump inhibitors to reduce gastric acidity and help with healing. You'd monitor them closely for any signs of complications, ensure they have gradual reintroduction of diet as tolerated, and of course, keep an eye on their overall recovery with routine post op checks. So, really, it's about pain management, infection control, and careful monitoring as they recover.
PPI therapy is initiated. H. pylori testing is pending. What follow-up counseling will you provide to this patient regarding ulcer prevention and long-term management?
Absolutely. So, for follow up counseling, I'd focus on a few key points. First, we discuss the importance of completing the full course of PPI therapy and any antibiotics if H. pylori comes back positive. We'd also talk about avoiding NSAIDs in the future or using them only under strict medical guidance. And if they do need to be used, making sure they're combined with protective medications like a PPI. I'd also recommend lifestyle modifications that can help reduce ulcer risk, things like limiting alcohol, avoiding smoking, and eating a balanced diet. And finally, we'd arrange for follow up visits to monitor healing and make sure they're doing well long term. So the emphasis is on prevention, lifestyle, and careful follow up.
In what scenario would non-operative management be considered for perforated ulcer disease?
Sure, that's a really good question. So, non operative management for a perforated ulcer might be considered in a very select group of patients who are stable, have a contained perforation, and have minimal signs of peritonitis or sepsis. In other words, if the leak is very small and the body has walled it off, and the patient is not acutely ill, sometimes a trial of non operative management with IV antibiotics, bowel rest, and close monitoring might be attempted. However, it's definitely not the standard approach and would be chosen only for carefully selected cases where surgery is high risk or the perforation is very contained. In most cases, surgery is the definitive treatment.
Understood. We've covered the key points of diagnosis, operative management, and postoperative care. This concludes the scenario.
The examination portion is now complete. I am your assessor. Are you ready to proceed with the formal assessment?
Absolutely. I'm ready to go ahead and hear your assessment. Let's proceed and see how I did.
Problem recognition was acceptable. You identified the perforated ulcer promptly and articulated next steps. Prioritization was borderline. Initial management included fluids and antibiotics, but operative timing could have been faster. Diagnostic choices were acceptable, including appropriate imaging. Operative judgment and steps were adequately described, though some details on timing and decision-making could improve. Adaptability was acceptable. You managed complications reasonably. Communication was clear and organized. Professionalism was consistent. Overall outcome, acceptable performance, with room for improvement in timing and thoroughness. This concludes your oral board's assessment.